the first step is, in fact, to do whatever is necessary to try to determine what the patient's symptoms are due to, because they're not due to ongoing infection with Borrelia burgdorferi. So that clearly is the first step. And then the management would be a function of what you find. It is on the list of causes of septic arthritis, and it can do that. And again, that's a misunderstanding. Lyme can produce a hot joint. It does not produce months of achy joints. That's not associated with Lyme disease. If you get Lyme disease in a joint, it's usually one joint, occasionally two. It's typically the knee, and it's full of pus. It's a hot joint, and it's diagnosable and treatable. Lyme is a cause of a heart block, and that is diagnosable and has treatments. Rarely, Lyme can cause an encephalitis or encephalopathy. One of the things I find particularly problematic is seeing patients treated with protracted courses of antibiotics because they have real significant to them, but they don't remember names as well as they used to, or they misplace their car keys more often than they think they did in the past. So somebody does some testing and concludes they have Lyme encephalitis. Dangerous. I feel strongly that one should not diagnose and treat that entity without objective evidence of neurological disease, which means more than just I can't remember names, either physical findings or abnormal neuropsych testing, and objective evidence that you have Lyme infection in your CSF by spinal tap looking for the organism or the antibodies. And in the absence of that, I think it's really dangerous to treat people with intravenous antibiotics, particularly since neurological disease may not get better or may not get better quickly, and so it can give the appearance that they're not responding to treatment. It's complicated. The fundamental issue is there's no test for Lyme disease, and I think a lot of physicians don't totally understand that. So they mistakenly diagnose Lyme disease because they find antibodies to Borrelia burgdorferi, which is no more sensible than finding antibodies to chickenpox and saying, well, your symptoms for the last 2 years are due to chickenpox. Having said that, the test is very, very good for ruling out Lyme disease. When we're infected with bacteria, we make antibodies. And the longer we're infected, the worse we're infected, the more antibodies we make. So it's not physiologically possible to have symptoms for 2 years, tiredness and headaches and other chronic symptoms for 2 years and have a negative test. So it's a very good test to rule it out. But it's not, there is no test available to rule it in. It's a clinical diagnosis supported by finding antibodies, but not proven. Acute Lyme disease is easy to diagnose and in fact doesn't need any testing. The bullseye is a bit of a misunderstanding. Most people don't have a bullseye. It's just a red patch. About 30% have a bullseye, and 5% actually have a vesiculating or necrotic center, which can, if you're not thinking about erythema migrans, can confuse you. But the bullseye is not the relevant issue here.